A very good morning to all of you. I would like to thank the organizing committee and the entire PCSI crew for giving me this wonderful opportunity to stand in front of you today. My topic is genetics, about genetics. So I'm a fetal medicine expert and with a special interest in genetics and fetal cardiology. This is an overview of my talk, and genetics is considered to be a boring topic, but I have tried my level best to make it interesting and give you some good messages. Okay. The genetic abnormalities are classified as chromosomal problems, single gene disorders, structural chromosomal problems, structural CHDs are associated with chromosomal problems as well as with monogenic disorders. Apart from that, there is a subset of channelopathies and inherited arrhythmias which are known to associated with single gene abnormalities. These are the types of genetic testing, right from karyotyping, which you're very much familiar with. Now, with the advancement in genetic technology, the gene sequencing has widely improved, and we are utilizing it for diagnosing various cardiac conditions as well. So genetic diagnosis is not a stepwise approach. It's not that you do a karyotyping and if it doesn't give an answer, you go for a higher testing. It doesn't work like that. We need to order an appropriate test based on the phenotype genotype match, which means we need to look at the clinical features as well as compare it with the genetic report and then counsel the couple and take them ahead. And for this, the one another important thing which we have to remember is to evaluate the index case properly. So I personally feel that cardiac genetics is very unique and very interesting because apart from the phenotype genotype matching, there is something called matching with the cardiac phenotype, which the information can be provided only by a pediatric cardiologist based on the echo and the ECG findings. So prenatal diagnosis and pharmacogenetics are two fields which are rapidly evolving well, and it's definitely improving a lot of families to have a healthy child. So by knowing the recurrence risk, we are able to do amniocentesis and CVS and help the pregnancy to have a normal baby. And there is a significant role of genetics in prognosticating and treating the subset of cardiac abnormalities like cardiomyopathies and inherited arrhythmias. How many women do you see here? Okay, I'll come back to this in a few minutes. So Mrs. R was referred for pre-pregnancy counseling at 10 months of age. She lost her first child due to suspected IEM. At a first look, there was nothing significant and we were not able to assume what it was. But when we looked at the echocardiogram report and echocardiogram pictures and the ECG, it was highly suggestive of pompous. So ideally, we need to test the first child, but unfortunately, the child is no more. So we tried to get the umbilical cord remnants that the couple had safely saved it. And we did a DNA isolation and performed a gene sequencing, and that proved that it was a pompous. So globally, this has not been reported in the past. This kind of genetic things have been widely done in forensic medicines, but not in the clinical practice. We isolated the DNA from the dried umbilical cord, and this got published in the American Journal of Genetics in 2020. Subsequently, the couple had a twin babies, and at 16 weeks, I did an amniocentesis and proved that they were just carriers and the family is happy. So the ideal case scenario is something like this, where we identify the disease in the index case properly during the preconceptional period. But why is that so? Why is the index case so important, and why not parental testing or any other member of the family? Because testing the affected member makes the job easy. When we evaluate in the preconceptional period, because genetic testing is generally slightly time consuming, sometimes we have to sit and work out the genotype, match it properly. So it might take some time. So preconceptional period is always ideal to predict the recurrent risk and prepare the family for the future. This patient was, sorry, okay. This patient was referred to our cardiologist. The baby actually came to our ICU in shock. And sorry, the clipping is not playing. The echocardiogram showed severe LV dysfunction with dilated LV. There was some significant history of cardiac abnormality and vision problem in the family. And hence we decided to go ahead with the genetic testing after counseling. And the child was diagnosed to have Alström disease, which has association with cardiomyopathy. So surprisingly, we had 2 Alströms in 2 years. Tiny Hearts is just 2 years old, and we had 2 cases. Another baby was referred to us at 3 months of age. The baby unfortunately collapsed when they came into our OPD. So Maniram did a postmortem echo for the baby to rule out Al Kappa because the baby had carried a diagnosis of dilated cardiomyopathy at 3 months of age. The evaluation was done by adult cardiologists. I think most often it's actually Al Kappa. So we need not have to do an autopsy as well, and we ruled out Al Kappa. So we went ahead with the genetic counseling and testing confidently, and we proved that the baby also had Alstom. The important message I would like to give here is genetic testing must be considered when we see a child with unexplained problem, terminally ill in the ICU. At least it's a good idea to save the DNA of the affected baby, so that it's really devastating for the family to know that they're going to lose the child, and we cannot go and talk about genetic counseling and talk about having the next child and all at that point in time. But still, the DNA will be very helpful to evaluate for this in the future. This mother was referred to us during her second pregnancy for a routine first trimester scan. Her pregnancy was terminated at 23 weeks in the previous 2 years ago, and because of AVSD in single ventricle physiology, the operator had thought it could be Downs, and she did an amnio, and it was normal. The evaluation was done elsewhere. This time, when I did a transvaginal scan and I looked at the fetal heart, I found that the baby had dextrocardia, AVSD, and pulmonary atresia. We all know that all AVSDs are not Downs, and there's absolutely no role of karyotyping on microarray in such cardiac anatomy. So, but why did this recur? On solving the puzzle, we concluded that it could be right atrial isomerism, and a series showed that the baby had a pathogenic mutation for right atrial isomerism. So the message is isomerism also can be familial, and we have isolated, we have found 2 families where they had recurrent right isomerisms and complex CHDs. This baby was referred to for a routine postnatal echo, failure to thrive at 3 months of age with some kind of murmur noted by a pediatrician. And the echocardiogram showed pulmonary stenosis with proximal LPA narrowing. The baby had dysmorphic faces and was referred to me for genetic counseling. And interestingly, the baby had an NGS report, a gene sequencing report, when they came to me. Because antenatally, the child was suspected to have short limbs and skeletal dysplasia. And soon after the birth, they did the NGS, which said it was normal. But this was how the baby looked. And we strongly thought of Cornelia de Lange syndrome based on clinical assessment. And when I looked at the X-rays, I was reasonably sure that it was not any primary skeletal dysplasia. So we went ahead and did a reanalysis of the whole exome sequencing. We did it by ourselves, and we found out that the child had the actually expected genetic condition. So we need to be very, very careful when we order advanced genetic testing. We need to properly match the phenotype and genotype and spot the mistake and relook and have a relook and go and do a segregation cascade analysis of the entire family, sometimes if required. And this information is going to be extremely useful for the couple, because this is something which will help them to have a normal, give a proper recurrence risk and a normal baby for the couple. So the parents were not carriers, and so we decided that it was a de novo mutation and told that there is no recurrence risk in the future. So we need to believe in ourselves, in our clinical evaluation, in our echocardiogram skills, than just going behind a lab report where the biometric informatics person doesn't know anything about all these. So I think we need to believe in ourselves before we do conclude all such kind of higher testings. So this child was diagnosed to be have bradycardia in the antenatal period, and the child was from Chennai, and the child had recurrent syncope, and genetic testing was done in the newborn because of unexplained bradycardia in the fetal period, and referred to our pediatric cardiologist for potential role of further medical management. This was the ECG, and the bottom one shows the genetic report of the child, which says that there was an variant of uncertain significance for long QT syndrome, which doesn't mean anything. It's actually not a long QT syndrome as per the report, but still, because our cardiologist felt the ECG is still highly suggestive of long QT syndrome, we went and did a reanalysis, and we found that the baby had a Timothy syndrome, which is an atypical long QTS. And I think most of us here might know that it would not respond to many medical management. And the baby had ICD at 17 months of life and is doing well. And I think, to my knowledge, this is the youngest baby to have an ICD in our country. So now we are in an era where genetics can dictate the management if used properly. And variant-specific therapy has already come into practice when we properly solve the puzzle and use the signs in a proper way. So this mother was referred to us for a routine first trimester scan. The history was nil significant, except for the mother had a AV valve replacement for RHD after her first delivery. and is not cardiac, but still the baby had an encephalocele. So will we think of chromosomal problem or genetic problem because of the structural abnormality, or are we really missing anything? The mother was on anticoagulant therapy, warfarin. So I think first common things are common. So I thought it could be more of a warfarin therapy, and I didn't feel the need for genetic testing in this, and we just terminated. So do not think always beyond the rare things. Common things are common, and we need to elicit a proper history. And this is something which in our unit, especially because we work, I am lucky enough to work with a pediatric cardiologist all the time. So ventricular hypertrophy in newborn and fetus. So especially when you see a hypertrophy in 3rd trimester or in the newborn period, I think often these babies are referred for echocardiogram because of prolonged oxygen dependency, I believe. And we need to always think of diabetes, maternal diabetes in such cases. Just ask the obstetrician to do a HbA1c and you will have the answer. And if you still feel that the ventricular hypertrophy is not coming out or is remaining, I think then they can go for genetic testing. So word of caution is interpretation error is very, very high in this modern, genetic world. And the lab variation is definitely something which we have to have in mind. And the most dangerous things, most of the companies are coming with a cheaper genetic testing, telling that we can do gene sequencing, but who's going to report it? And how are we going to monitor the reporting quality? So I think all these we need to have in mind, and better to send to an expert. So how many women do you see here? It's actually 4. So don't believe in what is shown. Please have a complete look. Okay, these are a few indications which I think, at least as far as cardiac genetic is concerned, we need to refer these patients to a proper geneticist or a fetal medicine person who does this. And very, very important point I would like to emphasize as a fetal medicine person is please do refer these babies during preconceptional period, because we have enough time to prepare the family, and we also have enough time to evaluate this, because the reanalysis, all these takes a lot of time. And so that if the pregnancy is advancing, it becomes very difficult for us to do an amniocentesis. And if the baby is affected, I mean, it's better to terminate before 20 weeks or so, isn't it? So this is our data in tiny hearts. We had 510 genetic counseling from 2019, and about 175 monogenic disorders. Only 1/3 of them were presented for pre-conceptional counseling. My focus is to improve this part. So the answer, I think everybody will agree that genetics is definitely taking us ahead in a good way, and everything is in our hands. It has to be a teamwork, and the neonatologists, pediatricians, and pediatric subspecialists are the people who get to see the affected babies very closely. And I think we need to have the genetic etiology in back of our mind and refer such cases. So this is the strategy we have been using, and we have been successfully running cardiac genetic clinic and inherited arrhythmia clinic at a small place, Tiny Heart, Tanjavur. And I'm very happy that we, especially in 2022, we were able to help a lot of our colleagues, doctors and families remotely through teleconsultation, and help them to arrive at a genetic diagnosis and help so many families to have a good baby.
Thank you.
So thank you very much.